Good afternoon, and welcome to the ANTHC Burn and Soft Tissue Echo. My name is Dr. Alicia Brownson. I'm the Trauma Medical Director here and will be the facilitator for this echo. Please mute your phones and pagers to minimize disruptions unless you're contributing during discussion time or need to ask a question. For those participating by VidWio, you may also use the group chat function. If you do have your microphone muted and want to speak during the didactic portion, please unmute the microphone so that you can participate in the discussion. We'll have a brief didactic followed by a case presentation. We will break for discussion after both of those portions. Also, as a reminder, CMEs and CEUs are provided for this event. Please see your email or the ANTHC website for details. So today I will be giving the didactic portion, presenting on delayed burn care and what to do in austere environments. If you have any questions about today's didactic, we will have an opportunity to ask them at the end of the didactic. So we'll begin with the presentation. As a general warning, we do show images of wounds, and those may be considered graphic or disturbing for people who are attending. So a topic that's all familiar with us as we're here in Alaska, but just to put us all on the same page and remind us about the challenges here in our unique state. We have the largest state in the United States with 570,000 square miles and a population of about 740,000, about 1.2 people per square mile. Many of our communities in Alaska are geographically isolated, and only 25% of our communities are connected by the road system. This makes us reliable on a lot of off-road transportation, including boats, ATVs, snow machines, and airplanes. And there's a lack of resources in a lot of these rural and frontier communities. Currently, 22% of rural Alaskan homes lack running water and a flush toilet, which again plays into our resources when caring for acute burns. Aeromedical transport is something that we're heavily reliant upon for medical care here in Alaska, but it is a finite resource. So there's only so many planes available in the state and only so many crews. So when we consider using aeromedical transport for things like burn injuries, we're taking that plane from potentially using them for another time critical emergency, such as a ectopic pregnancy or a patient in sepsis. So it's something that we have to consider about who has the greatest need for using that rig. Our aeromedical transport here in Alaska has improved over the last 35 years. We've been much more efficient with the development of regionally based services. And additionally, we've added a lot of safety measures, but it's still not perfect and does have risk. And NIOSH, which looks at occupational hazards, reported that Alaskan pilots have 5 times the mortality rate of pilots in the rest of the U.S. So when we deploy aeromedical transport, we put both the crew and the patients at risk, and we have unfortunately had several of those crashes even in the last year in Alaska. So we are aware of the risk that it puts our crew and our patients when we deploy aeromedical. Our distance to definitive care is unbelievably vast here in Alaska. So when we're looking at burn injuries that happen all over the state, we're looking at transporting patients over very long distances. You know, for example, from Utqiagvik or Barrow down to Anchorage, we're talking about a distance of about 800 miles, which would be equivalent from transferring someone from Washington, D.C. to Orlando, Florida. So we're dealing with problems that no one else in our country have to deal with, and want to be very mindful of that as we're taking care of acute burn injuries. Medivac, not only is it long distances and comes with risk, but it also comes with a financial price. This is Medivac cost by city. I know that the words are small on there, but the blue line below is the dollar amount for a Medivac to bring you from that Alaskan town to Anchorage. And the red line is the dollar amount to bring you from that Alaskan town to Seattle. And so you can see that the southeastern towns, Sitka, Juneau, Wrangell, Petersburg, and Ketchikan are almost equivalent for cost due to their geographic location. But however, if you look at sending a patient from Kotzebue to Anchorage, it's about $70,000, but a patient from Kotzebue to Seattle is almost $200,000. So making sure that we triage patients to the appropriate destination really does affect cost. Our health system in Alaska, we have 24 acute care hospitals. We do have 2 centers here in Alaska that are trauma centers, both adult and pediatric. They're in Anchorage and Alaska Native Medical Center, as well as Providence. We have 16 critical access hospitals around the state, and of those, we have 7 tribal hospitals. Our only burn center is our regional burn center, Harborview Medical Center down in Seattle. But we have 180 village clinics scattered across the state, and so really the backbone of our medical system are these really small remote frontier village clinics. So when we talk about austere environments, we really have to define what are crisis standards of care. So we can talk about normal standards for acute burn injury. I can tell my co-surgeon what I would recommend for a burn injury here at Alaska Native Medical Center when I have unlimited resources and I can provide the greatest good and really put a lot of energy into each individual patient. But there are certain situations when that is not feasible, and we think about those in disaster, in mass casualties, and also in austere environments. And at that time, what we want to do is follow a crisis standards, where we have an allocation of limited resources and we aim to seek the good of the greatest number of patients, realizing that we're not giving perfect care, but we're giving the best available care. And so that's really what this lecture will focus on, is what are those crisis standards for acute burn injuries. So this is just talking about crisis standards. It's something that can be established through peer review, through literature review, to help give providers the best resources for when they're in those situations. And so when you think about when we move from standard of care to crisis standards, we think about the demand of the acuity, the resources available, and the risk for how severe the injuries are with the patient. And so when you think about conventional, we think about space, that we have enough space, we have enough staff, and we have skilled staff, and we have plenty of supplies with backup supplies. That would be our usual care. We go into contingency plannings when we start to have overflow, when we are shifting patients around the hospital, they're not in their usual care spot, we still have beds, when we're maybe extending staff to cross cover, and when we're using supplies that we have but kind of conserving our efforts. But then we really go into crisis mode when we do not have a facility that is that would be the best or standard of care for patient area, when we don't have the adequate staffing or the most trained patient, or when we don't have supplies. And so a crisis standard of care can be established at any point, and it really determines on your local resources. So a disaster in Anchorage may be different than a disaster in Togiak. And if you have 2 burn-injured patients in a rural location, you are probably going to be utilizing crisis standards of care, because those 2 acute burn patients will likely overwhelm your small system. So it's good to have good standards even when we have limited resources, and to be prepared in your facility. So burn triage, just a little touch on that. Really, this falls under your health preparedness program, the goal nationally is that all hospitals, non-burn centers, would be able to stabilize a critical burn patient for 72 to 96 hours. In the case of a mass burn casualty, it is possible that the sickest will be triaged out first, and your local facility will have to care for burn-injured patients for up to 96 hours. And so all disasters really become local, because it comes about your local resources, your local staff, and we aren't able to follow the usual patterns of triage. So we're not talking too much about mass casualty, but burn triage is something that Rapidly you're trying to figure out who needs to be shipped first and who can you care for and stabilize locally, even if it's outside of your usual realm of care. So burn care in austere environments is what we'll talk about today. Really, this is for rural and frontier locations. This plays in a lot with delayed transfer, so getting patients out and how can we stabilize them. Also, how can we treat them when they've been delayed in preventing. It really talks about allocation of resources and use of local items. I can't tell you exactly what you'll be able to use in your facility, but I guarantee that you guys are all very resilient and creative about how to get the patients what they need. So we're not going to talk about usual standards of care, but rather those crisis standards to be used in austere environments. So resources to consider in your local center. Transport, what's your availability of transport? There's often constraints due to weather, due to the location you're in, due to maybe the runway having lights or not. Personnel is something that is a big thing about who is available at any time of the day, and also what level of training is available. Do you have a health aide? Do you have a PA? Do you have a physician provider? Who's available? And then supplies. Really, this is going to be dictating how you can manage an airway, how you can resuscitate a patient, what supplies you have for wound care or pain. I like to take pictures of the trauma rooms around Alaska, and they're very simple in a lot of areas. I have a lot of toys, bells and whistles here, but I applaud all of you who are working in more austere environments who are really stabilizing patients with very minimal supplies. So first things first, don't lose focus. Remember that to treat an acute burn-injured patient, even in the most remote or austere environment, you're going to evaluate using the standard principles of trauma management. We're going to remember our primary survey, our ABCDEs of trauma, and then move on to the secondary survey, which in burn injury includes that thermal injury assessment and really focuses on the size, the total body surface area of the burn wound. A little bit about airway. The best advice I can give you is to assess this frequently. Airways can change rapidly in burn patients, and the most important thing is that you always go back to that A and assess that airway. Things that you'll be looking for is changes in mental status, hypoxia, hoarse voice, stridor. Most times in austere environments, you do not have the ability to intubate a patient that may have a compromised airway. So things that you want to remember is that you can always use manual maneuvers, the jaw lift. You can use adjunct airways, so nasal pharyngeal or oral pharyngeal airway to be able to open that airway up. If you have oxygen, administer it in any way that you can if you're concerned about airway. So high flow oxygen, nasal cannula, non-rebreather, however you have oxygen. Other things that can be helpful is maintaining the patient in a sitting or head of bed position if there's no concern for a traumatic injury of the spine. This allows any facial edema to be decreased and will help them maintain their airway. And you may need to bag mask valve to ventilate this patient if necessary while help is on the way. Circulation. So the big thing for burns is to resuscitate the patient. What I want you to think about is if acute burns are big, aka are greater than 20%, then they're going to have increased fluid needs. And again, just briefly, burn shock is caused by inflammatory mediators that lead to leaky capillaries. So instead of a trauma patient on the tin can on the left that has a gunshot wound and is bleeding and is hypovolemic until you stop the bleed or patch the hole and you can fill the tin can, a burn patient has holes poked all throughout their capillaries and are leaky. So if you dump a bunch of fluid, you may not actually fill the tin can. They'll still be hypovolemic, but you're also going to cause massive edema. So we want to be very careful in how we resuscitate patients, and proper resuscitation early, even in austere environments, is very important to the outcomes of the patient. So what you want to do if you have a large burn is to just start some fluid. not to bolus. We don't like boluses in burn injuries, and so we've tried to make it easy. It's just based on age. If you have a big burn and you haven't calculated your full TBSA, just start an age-based rate. So less than 5 is 125 cc's an hour, 6 to 13 is 250 cc's an hour, and 14 and older is 500 cc's an hour. And then calculate that total body surface area as soon as possible. Our consensus formula stems to the anticipated needs of a patient based on their weight and their size of burn. And so we calculate out how much fluid they need in 24 hours. Our preferred fluid is lactated ringers. And then we divide that out, giving the first half of that amount over the first 8 hours, knowing that that's the time of the greatest fluid need. And for the purposes of the next couple of slides, the consensus says you can use 2, 3, or 4 cc's. We'll use 3 cc's for our calculation. So what to do if someone's delayed? If someone comes to you 8 hours after injury, what to do? Do not catch up based on the lost hours of consensus formula. If you calculated out that they need 12 liters of fluid in the first 24 hours and they come to you at hour 9 after injury, do not bolus 12 liters of fluid in 3 hours. The consensus formula is an estimate. It's a starting point, and so just start the rate of fluid. Remote access, there's multiple transfers, and so it's important that you begin proper resuscitation early and have good sign-out and good instructions to the Medivac crew of what you want done for the resuscitation and transport. We realize that we're doing long distances and times for transport, and there's also a possibility for that patient to decompensate hemodynamically or with their airway en route. So it's always these are very tricky patients that need frequent assessment. Also, you may have limited resources. You may only have 7 bags of LR in your clinic. And so how do you deal with that if you have limited resources that you're trying to resuscitate a patient with? So start with a rate, don't bolus, and assess the patient from there. So here's an example. This is a 25-year-old man with a scald injury. It was circumferential from the belt line down to the toes. He was 80 kilograms and approximately 45% TBSA. So initially, as soon as you see him, you know he's a big burn, you know he's an adult, you're going to start 500 cc's an hour. Once you calculate his actual TBSA, once you get that 45%, you're going to calculate how much his fluid needs are by calculating 3 cc's times his weight, 80 kilograms, times his percent burn, 45. That gives you 10.8 liters in the first 24 hours. We're going to divide it by 2 to get that half and divide it by 8, knowing that we're giving a rate of half of those fluids in the first 8 hours. That gives you a rate of 675 cc's an hour of LR. But what happens if he was hiking in a very rural area and you see him 4 hours after his burn injury? Well, we want you to start with that same rate. It's just a starting point. So start with that 675 and do not bolus to catch up, and then adjust the rate hourly based on the urine output of the patient. So if they're not making urine, you increase the fluids. If they're making too much urine, you can decrease it. But do not try to catch up for that 10.8 liter goal in 24 hours. Fluid creep is a social phenomenon that we are pounded in that burns need fluid, and so despite Parkland goals, it's estimated that when we see what patients actually get, they're all getting, a lot of them are getting over-resuscitated. If someone starts giving fluid and they give sign-out, then people typically give more fluid. It's very common when there's multiple care sites. So it's very important when in Alaska we know that there's usually 1 or 2 transfers to the defense site of burn care, that we start that responsible resuscitation early. This is very, this has been something that we've learned from Operation Enduring Freedom, Operation Iraqi Freedom, where the first several U.S. lives lost were burn injuries, and they all died of consequences from over-resuscitation because they were going to multiple care centers and getting over-resuscitated at each spot. So we have to be very conscious of this. Oral rehydration therapy is feasible and favored for small to moderate sized burns. If you have a burn less than 20%, do not start IV therapy. You can rehydrate them orally. For larger burns, it's usually not used, but if you have a larger burn, even up to 40%, you can orally rehydrate someone. If you do this, occasional episodes of nausea and vomiting are inevitable, and it's not a reason to discontinue the oral rehydration therapy. You should just pause it. Also, when you do definitively transfer the patient, discuss the MPO status with the accepting facility. They may need sedation for procedures on arrival. So when a Medivac crew comes, they may be able to switch over to IV therapy and keep the patient MPO. In austere environments, oral rehydration therapy, again, the GI tract can absorb up to 20 liters per day. If a patient really has severe nausea and vomiting, you can even give rectal infusion therapy with tap water or saline, and the colon will absorb fluid. But you want to give liquids equivalent to 15% of the body weight every 24 hours. Tell the patient to sip every 5 minutes, giving them 4 cups an hour. If they vomit, you wait 10 minutes and get them to sip. You can use Pedialyte, Gatorade, Powerade, or you can make your own rehydration therapy with a liter of clean water, a teaspoon of salt, and 3 tablespoons of sugar. Primary survey continued. After circulation, we've got disability, just monitor for changing level of consciousness, and E is very important in burns. This is exposure. Remove clothing for full assessment of the burn injuries. And then burns can be cooled with cool, not cold water for a few minutes. So we're not talking the ice bucket challenge. Okay, and then once you do a few minutes of cooling, they should be kept warm and dry. No saline soaks on the wounds. That will may cause hypothermia, and that's what we want to avoid. Once we get the patient cooled and dry, we want to make sure the patient does not become hypothermic. Many materials can be used to conserve heat. Clean sheets, blankets, and towels are often available. If you have things like space blankets, those can be used. I've seen plastic wrap used, large plastic bags, aluminum foil, anything to keep heat in. You want to use clean supplies and avoid circumferential wraps. That patient's going to develop edema, and you do not want to have a tourniquet effect if you wrap saran wrap around a limb. But you can lay it sheet-wise, lengthwise along the limb, and really conserve heat. Monitor the patient's temperature every 4 hours. If the patient becomes hypothermic, you can actually, another thing you can have in really austere conditions is have family members lay close to the patient to gain heat. I get asked a lot if you can microwave IV fluids. It's not recommended. It creates hot spots within the fluid, and so we do not recommend doing that to warm IV fluids. You can warm them up in a warm water bath. That's something that's more safe. Wound care, really we want an assessment of the wounds, the minimum of daily. Prophylactic antibiotics are unnecessary. If you anticipate a prolonged stay, if you're going to have a short stay, we just usually say wrap in a clean, dry sheet. If you have a prolonged stay, if they're stuck at your facility, you can wash the wound with soap and water, but you do not need to perform a formal burn wound debridement. So avoid scrubbing motion. Use only enough pressure to really remove loose debris. This is not a sterile procedure, but it should be clean. Regular gloves is fine. Tap water is fine. True burn wound debridement is painful and often not feasible in pre-hospital settings where you may have access to only oral medication. So it's okay to not debride a wound and send them to definitive care. Creams and ointments can be applied but may not be available. They always need to be removed at the definitive care site, so if you don't place it, that's okay if you just place a dry dressing. Pain management, pain and anxiety, both will need to be addressed. This is a variable thing for what you have available. Do consider renal function if you're going to try NSAIDs, but be prepared to think outside the box. You can be creative. If you don't have something in the clinic and you're in a really dire situation, you may be asking other members in the community who may have medications at home. With the legalization of marijuana, this has become something that's been a hot topic with austere environments. So there are other things that you can do. Think outside the box if you're really in a stuck situation. Non-pharmacologic options, we want to minimize pain of the injury, so elevate extremities, cover the areas. Burn injuries open to air are very painful. Minimize the mechanical handling of the burn wound, and provide emotional support. This is variable. Family can both hinder and help the patient, so be wise about how you try and use emotional support for the patient. Transfer, call early for resources. As soon as you know that patient has exceeded your facility, you should be getting on the phone to get them transferred. Even if you cannot get them out, often you can get support from the field, including telemedicine, which has really helped with burn wound care, can help give an assessment of burn wounds, and can help guide providers. That's the lecture that I have. There is additional burn education on this topic. The 96-hour project helps train non-burn facilities to review burn practice guidelines. It's an online, it's a free registration, and you can get free CEMEs and CEUs if you're interested in more of this topic. So that is the lecture. I have gone a little over time, but we'd like to open it up for any discussion or questions that people may have.
Hi, Dr. Brownson. This is Denise Smith, a nurse at ANTHC, and my question is, crisis standards of care, we talked about them a few years ago, trying to formalize them with across the state to see if there was some way to initiate crisis standards of care that all the facilities would acknowledge and it would be acceptable to the Board of Nursing, etc. Do you know if there's been any more work about setting or establishing crisis standards of care?
I don't think that crisis standards of care for burn care have been adopted. I know that they have not been adopted in Alaska. It's something that the burn standards of care were recently, just in the last 2 years, formalized through the Western Regional Burn Consortium. The state trauma committee is working on discussing and developing burn triage protocols and may be able to address that. I can't speak to other crisis standards of care statewide. Angie, do you have any comments or input on that?
No, I don't. I haven't heard that it's been formalized over the state yet, but we can look into it.
It sounds like, I mean, to me, this is a state that has a high need for this type of standardization and helping our rural and frontier clinics if they are in this situation.
And just a quick second question, do you know, is there anything that's been recommended to LifeMed or Guardian, anything special that needs to be considered about burns and altitude, or anything different, how patients should be bundled up for transport?
Yeah, so a lot of the things that, so I have worked with some of the Aeromedical Transport systems to review their burn protocols, and I'm always happy to be a resource for that. Things that we consider in transport is keeping patients warm. Patients often lose temperature during that flight. Keeping patients, keeping limbs elevated to avoid edema, and keeping wounds nice and dry. So a lot of what we think about the actual transport itself is a lot related to hypothermia. Again, I did reference that when a patient has burn resuscitation started, we try and give pretty clear recommendations to the Medivac crew to monitor urine output hourly. Often our Medivac here in Alaska will be over an hour of transport, and so we want them to know what their goals are for urine output and what we want them to do with the fluids during transport. That's all very important. And often our aeromedical crews are the ones first addressing the burn airway. So we want to make sure that we have very skilled providers. They've done an excellent job with airway management across the state, but they're usually the first ones to assess that airway and be able to do a type of intervention. Okay, well, we will open up for questions again later after the case discussion, but now we're going to transition to introductions.